and I'll be talking about fulminant endophthalmitis and how we go about salvaging the eye. Now, fulminant endophthalmitis is SOS basically from the eye, and unless you are really aggressive, you can lose the eye very, very quickly in spite of your best efforts. So I have no financial interest to declare. Now, where do we see fulminant endophthalmitis? We see it sometimes when you have post-surgery endophthalmitis that is progressing rapidly, either because of the virulent organism. Sometimes in post-traumatic cases, you have unusual organisms, or it is a polymicrobial infection, and that, along with the comorbidities, spreads really fast. Sometimes endogenous endophthalmitis that we see in patients with compromised immunity or drug abuse, or sometimes even in neonates, is quite fulminant. And a lot of times post-injection endophthalmitis, if you have, we've had incidents of counterfeit medication, and these cases usually get delayed attention because it's not a surgery. Patient goes home and comes to you quite late. Some traditional surgeries, especially by quacks, can also lead to very bad kind of a picture. Now, what leads to poor outcomes and endophthalmitis? One, of course, is the highly virulent organisms, and the second is drug resistance, which we are seeing more frequently nowadays. These are aspects that we need to tailor our therapy accordingly. Late presentation and delayed diagnosis can also result in poor outcomes, and a lack of timely specialist support or appropriate instrumentation can lead to loss of the eye. A lot of times, inadequate drug concentrations or control of inflammation and the associated complications present along with the endophthalmitis can also cause trouble. Now, the aims of treatment are: number one is to sterilize the eye, number two is to control the inflammation, and number three is to assess the comorbidity. Then we'll be looking at that now. Sterilizing the eye, microbiology is of paramount importance. You need to use all that is available at your disposal, including routine microbiology and PCR techniques to find the bug. Unless you find it, you will not be able to neutralize it. Vancomycin, ceftazidime, of course, is the first line, and for fungal, amphotericin B is supposed to be better than voriconazole for post-traumatic cases, especially. We have to be very quick in antimicrobial escalation in cases of fulminant endophthalmitis. Linezolid for gram-positive, piperacillin tazobactam plus or minus colistin is usually employed for gram-negative, and for fungal, either voriconazole or caspofungin can be employed. So in case you do not see the desired response to your antibiotics, the routine antibiotics, escalation should be pretty fast. Also, early surgery is a must. If the media permits, and even if there is a severe inflammation, you should go for early surgery. There is an increasing trend with the instrumentation to not wait conservatively with endophthalmitis. And if there is a comorbidity like RD or a foreign body, then of course there's no question you have to go for early surgery. If the media opacity is such that you cannot operate, then of course you defer it. If you have choroidals, you may wait for a couple of days, or if there are certain other systematic factors in the patient, then you may want to defer the surgery. Severity of endophthalmitis is basically the severity of inflammation. So inflammation is to be controlled with the utmost aggression. Macular edema, membranes, retinal detachment, and hypotony are all long-term complications that can happen even if you sterilize the eye, but you fail to control the inflammation. So vitreous acts as a reservoir. That's why early vitrectomy with a PVD induction and a vitreous lavage multiple times, sometimes AC wash, is essential to reduce the inflammation, and systemic and intravitreal steroids need to be given fully as and when required. Now, this is, I'm just going to present one video in my talk, and it highlights several principles. First, in fulminant endophthalmitis, sometimes your view may be really bad and you don't even know what your landmarks are. You sometimes see a faint shadow of a disc, and you get your orientation from there. And sometimes you may see certain collections of exudates that you may mistake for the disc. So you are basically on your own, especially if it's also complicated by trauma. You may have heme, and that further confuses the picture. So one of the key identification marks is the presence of vessels and of branching of vessels that leads you to go back and identify the disc. And from there, you can carry on your surgery. If you have a lot of inflammatory membranes on the retina, it is probably best to induce a PVD. And I personally prefer to induce PVD in all my cases of endophthalmitis. And in this case, this patient had a ricochet injury. This had a foreign body and a ricochet injury just below the disc. And if you see here, I'm trying to gently induce the PVD. Now I'm at least able to see the disc, and those are the collection of exudates around the blood vessels. Now, and this shining thing you see, this is the foreign body. Now, before I attempt to actually take the foreign body out of the eye, I am trying to attempt a PVD. Now, sometimes when there is a delay, there in a case with endophthalmitis in foreign body, there may be fibrous bands also. So here, as I am inducing the PVD, I'm going very, very gently, removing whatever little bits and pieces of the vitreous that I can. And now here we see that when I'm inducing the PVD, probably there was a small break which got enlarged, or maybe that incarceration that got freed from there, and that has resulted into this break and bleeding. Now, this is the time that you don't panic. This is the time that you don't panic, and the best course here is to go ahead and do the surgery that is possible, in the sense that don't try to complete everything in a single go. So here I freed the break from all the vitreous all around. And after freeing this, I go ahead and induce the PVD gently further till the mid periphery. This is what it looks like after I am satisfied with my vitrectomy. We, of course, then go ahead and remove the foreign body. Yeah, this is the foreign body lying on the retina in the inferior periphery. We identify that, pick it up with a magnet and use a handshake technique and transfer it to the foreign body forceps and remove it out. Now, what next? How do we address that hemorrhage and the break near the disc at the posterior pole? So this is another point that I want to make. You don't need, like I said, you don't need to do everything at the single go, especially in cases of fulminant endophthalmitis or in cases where the view is really bad. You can do a stage surgery. So in this particular gentleman, we had put in oil, and this is the follow-up that you see over a period of time. In approximately 1.5 months, the heme has gone away, and actually what appeared to be a fairly large hole has actually shrunk and become a very small area. And approximately 1 month, we did the laser around the break, and it scarred. And this is the patient. This patient achieved 6/6 vision at the end of the follow-up. Another important thing that we very routinely do, I do it in almost all my cases of severe endophthalmitis, is a two-port lavage. We do a core vitrectomy or a first intervention, and we remove most of the vitreous along with the inflammatory exudate. But then, like I said, it is infusion that kills in endophthalmitis. So every single time that 48 hours, when we repeat the intravitreal antibiotics, I take in a IV line connected to a bottle, connected via 26 or 24 gauge needle. And on the opposite side, I again introduce a 26 gauge needle at the pass plan and just start the flow. And I keep waiting there for patiently for at least 4 to 5 minutes. That makes sure that at least all the vitreous cavity fluid has been exchanged 2 to 3 times with fresh fluid. Not only does this reduce the bacterial load or the inflammatory load, it reduces the cytokines and the deposits that are happening at the macula. So you have a milieu that is now less, that has less inflammatory cytokines, less muck than before. It improves your view also. And at the end of this procedure, we take out both the needles and then give the intravitreal antibiotics as usual. Handling comorbidities is the third and rather final thing which will help you save the eye. If you have corneal issues, especially in foreign body, you have an entry wound, you do imaging if you have an entry wound. If there are lens issues, you have to remove the lens, and you have to handle poor view. For corneal issues that are unsurmountable, when the scarring is too much for you to see anything, then you may require to use the temporary keratoprosthesis for surgery. You have Lander's keratoprosthesis available that can be sutured on, and then later on at the end of surgery replaced with a graft. Do you do a complete vitrectomy? I always induce a PVD at least up to the mid periphery, but I usually do not do a base excision because the retinal thickness routine anatomy states that it is very thin, and a lot of the inflammatory mark is there, and there may be necrosis of the retina or inflamed retina there, which is very prone to tearing. So I am not in favor of extensive vitrectomy, even though some people say it reduces the microbial load and the substrate for vitreous growth is removed. Well, this is not true. If you go for the math, even if you just leave 1 million organisms per ml, which is hardly anything at the end of your extensive vitrectomy, by the end of 20 years, you're going to have a billion organisms again per ml. So you really don't do much by doing just a complete vitrectomy. And vitreous is not blood agar, basically. Bacteria and fungi grow very well in BSS also. So just filling the eye with BSS, removing the vitreous is not going to help. Also, there is a school of thought which says that put in silicone oil whenever there is severe endoff, because some people have proposed that it has antimicrobial activity. Some people say that it prevents detachment and improves media clarity. However, I am actually not in favor of this. We did an experiment, where we designed these wells in nutrient agar. We made these wells which are the size of our eye, that is 24 mm diameter. And then we filled this with half of them with silicone oil and half of them with BSS. And we inoculated them with cultures of bacteria and fungi. And see, this is Staphylococcus. It grows very well under oil also. In BSS also it grows very well under oil. Gram-negative organisms grow very well under oil. They easily coat the whole of the agar surface. And this is Candida under oil. So oil does not have any anti-microbial effect per se. Also, the problem is that vitreous is not an impediment in the intraocular spread of antibiotics, but silicone oil is. And there is sequestration of all antibiotics, sometimes antibiotics in oil when you inject inside oil. More so, whenever you inject oil, especially in an inflamed eye in poor visualization conditions, you're not very sure of the silicone oil fill. These are MRI images which show that the amount of fluid behind the silicone oil in so-called proper fill is quite variable. And you have absolutely no idea of the fluid compartment, and you may go very grossly wrong with your calculations of antibiotics and have toxicity. So the other thing that I want to highlight is multiple surgeries. Surgical